welcome to The Dose. This week I'm joined by Professor Ibrahim Abubakar. He is the Dean of the UCL Faculty of Population Health Sciences. Professor Abubakar, thank you so much for joining me today. How are you?
Fine, thank you. A pleasure to be here.
Fantastic. Now, in preparation for meeting with you today, I realize you've been busy. It would have taken me.
I like busy. I enjoy being busy. I say to sometimes that that's what drives me actually.
Yeah.
Being busy, as long as it's productive busy.
Productive busy. That's good. Do you have time for any fun?
Absolutely. With my lovely family, I have two lovely kids and my wife, and that keeps me busy too.
Fantastic. What do you do for fun?
Travel. We travel. So this weekend I was in Geneva.
Nice.
And sightseeing, walking around the lakes. We go for long walks in the countryside, so I love walking around the English countryside, and it's good exercise as well as productive for the mind and the soul.
Brilliant. Nice. Now, your work focuses on the epidemiology, prevention, treatment of infectious diseases, particularly in underserved populations. What sparked your interest in this area?
So I come from the north of Nigeria, and I would say as a child I came from relative privilege, and I use the word relative deliberately because of course there is actual privilege in certain subsets of even the poorest countries, and I wasn't from that super privileged background, but enough privilege to be able to see what poverty and disadvantage does, but also to have the platform to have a very good education, to go to university, secure a medical degree, and then be able to see actually a lot of what people suffer from and what reduces their productivity and opportunity to contribute is the toll of infections, is the toll of poor access to healthcare, and relevant preventive measures. So I kind of have it in me that the way I can give back and the way I can have impact through my career is to focus on those things that disproportionately affect the poorest in society.
Amazing. And do you remember what your first job was in this?
So my first job really was when I qualified as a doctor, and it's a regular clinical job in a hospital, in a teaching hospital in northern Nigeria at Ahmadu Bello University. And I would say that although it is a university hospital, our patient population was a mix of the very poorest in the city of Kaduna, as well as some of the privileged elites that live around there when they have complicated illnesses. And I reckon that I had some of my most stark exposures to the impact of disadvantage while working in that system. I remember some years after I graduated, not in my first job, having to deal with the 1996 meningitis epidemic and the row of patients that were brought in for what is largely a preventable condition and died needlessly. And it's one of my memories of that kind of formulated my idea that I needed to move beyond clinical medicine to understand the determinants and drivers of disease in populations.
Amazing. And once you kind of made that decision, you then decided to come to the UK to continue your education?
It's probably a bit more complicated. So my journey entailed doing a little bit more clinical training, and I was a senior registrar in medicine by the time I chose that I wanted to acquire population health and public health training. And I came initially to the London School of Hygiene and Tropical Medicine and studied for a master's there. And then following the master's, I secured a postgraduate training number, which the UK training system requires you to specialize in and you get a training number, and then you train for a number of years in Cambridge. And I spent a number of years then specializing in public health, but with specific focus on infectious diseases and health protection.
Okay. Now, you have chaired different commissions, strategic and technical advisory groups, some of which include the Lancet, World Health, Wellcome Trust, to name a few. Which one of those would you say has been the most, not exciting, but has allowed you to have the most impact?
So you contribute to society in different ways, and I would rate the piece of work we did on the Lancet Nigeria Commission as probably the one that is easiest to show a direct link between the science we do and the evidence we gathered and actual policy changes and impact. So when I thought about an area of work to develop that would have impact, in conversation with the editor of the Lancet, Richard Horton, we alluded to what can I do next after I completed a commission on migration and health, and I saw a piece of paper in his hand where he'd scribbled Nigeria, and I reminded him that, Richard, do you know that I'm Nigerian? And he said, yeah, of course. And he said, well, he was looking at statistics about Nigeria and saw the projections that Nigeria in the next few decades will be the third most populous country in the world, superseding the US. And I said, well, let's use the platform of the Lancet and do something about Nigeria. And I used my networks to get some of the best brains within the country, so in major hospitals like UCH, in the University of Nigeria, Nsukka, at Bayero University, Kano, as well as the Nigerian diaspora in the US, here in the UK, across Europe and Australia. And I brought together a group of Nigerians, and we worked over 2 years and looked at the entirety of the health system and made specific recommendations supported by evidence. I'm delighted to say that because we engaged really early on in the process with the health system, we were able to contribute to the formulation and passage of a law that changed how health insurance is delivered, with an offer to create a vulnerable group fund which would provide health insurance for the 83 million poorest Nigerians, but also to make health insurance mandatory for employers to provide. If and when that law is fully implemented, I reckon it would have been perhaps the best piece of work of my life.
Wow, that's amazing. That's amazing. Now, just touching on the Commission report and the new law regarding health insurance, it did say that this health insurance will make provision for 83 million of Nigeria's poorest people. That instantly made me think, are there 120 million plus people who can afford a health?
So afford is a relative term here. So if you're thinking about a first world gold-plated health insurance system, there are almost certainly not 120 million Nigerians. The 80 million we are referring to are those that cannot afford even the most basic forms of health insurance of the magnitude of 5,000 naira. That's sort of the level we're talking about. So these are really, really poor people that can't afford the most basic of health coverage to treat malaria, to prevent respiratory tract infections in their kids, to prevent maternal mortality. And it's that level of healthcare that we think, as a minimum, that the state should provide through innovative financing, increasing the fiscal space, i.e. not taking away from other social programs, but actually generating new revenue through, for example, a levy on telecommunications, which it's everywhere in Nigeria, and then use that to provide basic healthcare for the poorest.
And how long do you think it would take to be able to implement this to a level where it's actually covering 83 million people?
So the system isn't starting from zero. There's already provision in the Basic Healthcare Fund, which is part of the National Health Act that was passed by the previous government, Goodluck Jonathan's government, and has been partially provides the partial resource to begin something of this magnitude. So my view is that some of the resource already allocated to that could be transferred to provide that. And then the next thing that needs to be done is a modification of the Finance Act to increase the numbers and then gradually increase the fiscal space. So I reckon they already have resources in the system to provide the most basic healthcare at the sort of 5,000 naira level to tens of millions of people. And therefore the additional steps needed to reach 80 million people is actually doable.
It's doable. Okay. Now, just on that statement, it's doable. I mean, we know the cost of not having universal health coverage. Essentially, Nigeria is paying with the lives of its people.
Yeah.
But do you think it's achievable for Nigeria to have universal health coverage across the board? Do you think that is achievable given the current state of the country?
So the crux of the matter remains what you mean by universal health coverage. Again, I would qualify that if you're thinking about access to hospital services, secondary care in the way provided in most of the world with and tertiary hospitals, then the sort of funding we are talking about that would go into the vulnerable group fund is inadequate to do that. But if you're talking about the provision of the most basic primary health care to prevent kids and women during childbirth from needlessly dying, then it is possible. Countries that are and populations that are as poor as Nigeria, in Ethiopia, in Ghana, in Rwanda have done exactly the same with similar magnitudes of money. I'll give you an example. So with the Lancet Nigeria Commission, in an accompanying paper, we did an analysis of health spending across West Africa and compared Nigeria with the neighboring countries and looking at how much they spend and their health outcomes. And countries with far smaller health spend than Nigeria are getting better health outcomes and are improving over time. So I am confident that it isn't the absolute lack of resource that is the problem. It's actually utilizing that resource effectively. That's not to say you couldn't do a lot more and improve Nigeria's human capital by spending even more. That's just to say, even with what exists, you can actually improve the situation immensely. And then if you can increase the fiscal space, then you can definitely change the trajectory and human capital of the country. And just to add one more point, spending in this space, we articulated in the Commission, should not be about just helping people. It's actually about improving the livelihoods and economy of the country, because a healthy population will be economically active.
Yeah. Yes, I do remember the report mentions that one of the things that is missing is this social contract between the people and the government. But how do you think they can build this social contract, and how do you get the average Nigerian to actually believe in the government to an extent where it's kind of like a collaborative relationship?
So this is one of our central messages in the Commission, which we hoped that multiple politicians would pick up. A nation state, a modern nation state, relies on a social contract between the citizens and the people who are governing them. And as illustrated by the election that are just happening in Nigeria, the dire split in people and interests, either voting for people who are from the same ethnic or religious group as them, with absolutely no consideration of the consequence of that vote on their livelihood, suggests to me that Nigeria is in dire need of that social contract with citizens. In many parts of the world, how you deal with that is there's something in it for you that the state provides that you know you won't have if the state doesn't exist. These tend to be large social programs like pensions or the provision of healthcare or national security or some measure like that. And we in the Commission decided, having looked at the evidence, that actually health could provide that. If a leader can have the courage to provide healthcare in the form we articulated, that for the majority of Nigerians, they know, I can get healthcare because I'm Nigerian. Then it begins a conversation that means that you want to support Nigeria and the good of Nigeria and elect good leaders because they will continue to provide you with that fantastic service. And so we made the point that what we need is a refresh of a social contract between the leaders of Nigeria and the citizens of the country.
Okay. Now, the recommendations that you made in the report, fantastic. Some of them are things that we're sure the leaders should be aware of. Some of them may be things they haven't considered in the way that they were recommended. But how long do you think, let's say the necessary finance was available and the will was also there, how long do you think it would take to implement these recommendations and have the health system in a better place in Nigeria?
So you don't need to go the whole way to improve and save millions of lives, and literally millions of lives. We have modeling within the paper that shows for various amounts of spend, so marginal increases in money, how many lives you'd save of kids and of pregnant women. And we have some elegant charts that articulate that. So my view is, rather than looking at how long it will take to do everything in the Commission, which is an all singing, all dancing set of recommendations, is how do we sequentially go through the highest value, lowest cost measures that we recommend and get them out there and save as many lives and improve as many lives as possible. And some of those low-hanging fruits, already there are resources within the system as exists to do them. Others, such as improvements we recommend in the wider determinants of health in secondary and tertiary care, will take a bit longer to implement. So I won't focus on how long it will take to do everything, but how long would it take to do the most impactful, lowest cost items. And I think that time for that is quite short. You could do it in a few years and make all of the difference and transform healthcare.
Okay. So what stage is this commission at? So you worked for 2 years. The recommendations have been given. We all have access to read. Where is it now in terms of the next step?
So what we purposely did was we, of course, because a large proportion of our commissioners were based in Nigeria in different universities and policy positions, we launched the commission report in Abuja last year, and we purposely engaged with policymakers. So we had the Vice President Yemi Osinbajo launching the report, and he made a commitment in that he would engage us actively. And as a consequence, when he was tasked with leading a health reform committee, he invited me and a number of our commissioners to join the health reform committee and contribute to their thinking. But we were also careful and purposeful in that we purposely engaged the full spectrum of Nigerian society, and we fed our recommendations into the thinking of wider civil society actors as well as the opposition parties, so that some of the ideas we have, I am confident, has influenced the conversation irrespective of the outcome of the election. It is likely that we would put out the offer to whoever ends up being the president of Nigeria, that we are happy to provide technical support and continue supporting them to implement the recommendations. And there are many excellent recommendations in there for them to pick up.
Okay. Now, as we know, and I had you mentioned, Nigeria just had their elections. So, assuming you get a call tomorrow from Mr. President, and he says, Professor Abubakar, I would like you to be the health minister of Nigeria. Whether or not you will accept the job is a different question. But if you were the Minister of Health, what 3 things would you prioritize, say, in your first 100 days? What would be your top 3 areas of prioritization?
So I definitely would have a focus on maternal and child health, because I think that the number of lives that are lost needlessly in that space is something that is rectifiable in a modest amount of time with the right effort and attention and energy to those. I would look at health system financing and look carefully at how we can improve accountability for the resources that exist, and how you can increase the amount of funding that is going into the system, and have a performance-based allocation of funding, which is one of our recommendations, program budgeting analysis and all of the measures you could do that allows you to say, if I put in X amount, this is the results I get, and if I don't get more, I won't put it. Dealing with some of the leakages that exist in the system as well in parallel. So that would be a second measure. And then my number 3 would probably be a combination of things, because there are programmatic things that if you don't do them, you can have really high risks. And I'm thinking here specific things like immunization and immunization programs, engagement with the wider social determinants of health, because health is not just about the health sector. I'm thinking about global health security and being prepared for the next epidemic and outbreak. And there would be a very short priority list of projects and programs that would be managed with an end date, so like a task and finish type intervention. So if I was forced to choose, I know I cheated because my third one is a multitude of things, but it would be maternal and child health. It will be about improving health financing and delivery of outcomes. And then finally, it will be about task and finish groups for specific areas. But to go backwards, A, I don't think it's unlikely that I'm going to get a phone call. And B, I suspect that even if I do get a phone call, my demand will be, would I have the freedom and leverage to alter the system And if the answer to that is no, then it will not be the job for me.
Interesting. Interesting. You mentioned, infant and child mortality, and it's heartbreaking when you hear some of the numbers and figures around this, especially like you say, because it's just so avoidable. You also mentioned social determinants of health. We have problems around water and sanitation, and I do often wonder, is this a funding problem? Is it a problem of will? I mean, just as a layman, I'm a Nigerian, but as a regular person just looking from the outside in, I just wonder, what is it that it seems like such a problem that should have a quite basic, straightforward solution. What do you think is actually causing such a delay in fixing these things?
So I think there's a common thread across the whole of the system, which entails poor governance of systems and poor management of systems. And I don't think it's unique to health. When people wonder why isn't the health system functioning well, it's actually the same issue with the water system, it's actually the same issue with the sanitation system, the same issue as to why the public transportation system do not work. It's basically a problem of management and governance. Obviously, with 200 million and the level of per capita income, Nigeria is a resource limited setting. So the absolute amounts of money are a challenge, but there is enough to do the basics. There is enough to provide basic sanitation and water to people. And health, as I alluded to earlier, is about more than hospitals and the provision of curative services. It is about all of those wider determinants. So if you are serious about altering long-term health, you need to be able to reach out to the other ministries responsible for water, for sanitation, for other determinants of health, and provide those as well and run them equally well.
True. Okay, so just moving away from Nigeria for a moment. I know you've done a lot of work around TB. Now, we were able to develop a COVID vaccine within 6 months. Why do you think we still don't have one for TB?
So this is a simple issue of global prioritization and essentially a neglect because TB declined largely in the Western world, and therefore because it affected the poorest and least resourced parts of the world, it has not had the same amount of research and innovation needed to make a difference. I have no doubt that if the sort of global energy that was exerted on COVID-19 research was put to TB, we will have an effective TB vaccine. I'm delighted to say that actually it's now a very topical subject. The World Health Organization just launched a report on the investment case for a TB vaccine. On the back of some of the innovation on COVID, such as the mRNA vaccines, there are phase 2 trials that are just starting for candidate vaccine in that sort of space. And if that vaccine is effective, even very modestly in preventing TB infection, it will be a game changer in the global TB control effort. So I'm looking forward to the results of those studies, but importantly, the high-level conversations that will be happening later this year in New York around TB and the prioritization of TB control globally.
Okay. Just touching on a point you made that, there are some diseases that are just not as felt in this part of the world. Do you think it's the responsibility of the countries that are burdened with these types of diseases to take more action, or should that expectation not be put on them because perhaps they don't have the resources or just not there yet?
So we live in an unfair world, we live in an unequal world, and I would say that the answer to your question is we need both. We need places that have a high burden of disease to take some level of control and within the limited resource they have to invest in both the research needed but also in the provision of services. But we do need the wealthy world also to contribute because ultimately the sort of level of resource that you need to discover the cures and to run the treatment programs are just not available in the poorest countries where these diseases are rampant. And for some diseases, we live on a common planet. It's ultimately going to be the case that if you don't do enough, it will affect the rest of the world eventually. I mean, pandemics come to mind. And some of our work on the Global Preparedness Monitoring Board, which I sit on, which is convened by the World Health Organization and the World Bank, is in fact to task the world about what do we need to do to prepare and how do we monitor that preparedness commitment, and what is the accountability systems for that preparedness across the global architecture. And I'm pleased to say that in some areas the world appears to be taking this seriously. For example, there's going to be a high-level meeting in New York again on preparedness and response, with the expectation that heads of states would appear and make serious commitments. To some level, we are nowhere near prepared. So just last week, the GPMB, which is the Global Preparedness Monitoring Board, launched its manifesto, which is 3 questions to ask: is the world ready for the next pandemic? And the conclusive answer to all 3 questions is we are not ready for the next pandemic.
We weren't ready for the last one.
Indeed.
Oh, good.
Okay, so there's another pandemic coming.
Well, so I remember at the inaugural lecture, which the current Chancellor, Jeremy Hunt, attended at the Global Business School for Health, I did make the point that some of us did predict that there will be a pandemic, and it will likely be by a coronavirus. In fact, that book on the shelf, there's a chapter that actually states that before the pandemic. So, but I'm not the only one. I think lots of people thought that there will be a pandemic. Sadly for us, it's actually not a question of if, it's a question of when. And the interval between pandemics will shorten simply because we're encroaching into more habitats of animals and places where there will be greater opportunities for viruses to cross species and infect man, and partly because we move a lot more than we did even 50 years ago. So if you combine those 2 things, the probability that there will be a new pathogen is actually a lot higher than it was 20, 30 years ago. And so we will see another pandemic, and sadly, likely in our lifetimes.
So we're not prepared based on the 3 questions that, but if the time gets shorter, is there hope that we'll be getting better?
Hope that we'll be getting better at responding to the pandemics. Yes,
pandemics.
So that's the whole point of enterprises like the Global Preparedness Monitoring Board, to encourage, work with countries, work with global systems such as the WHO, and create the systems that means we're better prepared, so that when the next one comes, we quickly develop the vaccine, we roll it out, and we ensure that we contain the epidemic, hopefully at source, but if not, make the pandemic less impactful.
Okay, that's very interesting. I'm curious. You're an epidemiologist. What do you think the future of not necessarily the whole health sector, but perhaps within the space that you specialize in, what do you think the future looks like in, say, 10 years?
So before the pandemic, if you tell someone you're an epidemiologist, they go, what? And then you have to explain what you do. I'm pleased to say that lots and lots of people kind of now, if you say the word epidemiologist, kind of get what you do. I do think because of the importance of information technology, because of the importance of data, and because of the importance of global threats like climate change and anthropogenic climate change, infectious disease and pandemics, and challenges on how to manage health for populations with increasing costs, actually the position of disciplines such as epidemiology would become even more fundamental, because it's the sort of science we need to understand the related data to make things better, to look at things at population level and look at the distribution and determinants of disease and make recommendations on how to improve them. That's what epidemiology is about, and there will be more of it in a decade than there is today.
Amazing, amazing. Thank you so much. It's been wonderful speaking with you today.
My pleasure.
Thank you
Nice
very much.
speaking to you.
Nice speaking to you.